Hello, my name is Diane, and this is my final project for STAT 515. My final project will be looking at emergency room data and looking at the utilization and admissions cost, tests, and procedures done. So just a little bit of introduction. Emergency room care is one of the most expensive components in U.S. healthcare. Costs have risen dramatically, and it's really important understanding the drivers of high ER expenditures and admissions to help policymakers and hospital healthcare professionals to create more efficient care pathways and reduce financial burden. So these are my three research questions. It looks at predictors that can help determine whether an ER visit results in an inpatient admission. The second one is characteristics that are mostly strongly associated with high ER expenditure. And the third looks at what impacts the number of tests and procedures a patient gets done in the ER. So kind of looking into the data, so the data is from the Medical Expenditure Panel Survey. It surveys a diverse population in the U.S. Not only does it survey the patients, but also their medical providers, such as doctors, hospitals, and pharmacies. And only emergency room visits data was included in the data set. The original data set had that had 4,241 unique patients and 53 variables. These variables included services and procedures done, diagnostic testing, medications provided, total expenditures, and sources of payment, as you can see down here. So of the original 53 variables, I selected 23 that were relevant for the research questions. The variables had don't know, refused, or not received, which had negative variables, which I recoded into 0 or either 1. So as well as with the admission outcome, 0 or 1, a binary variable. I also created a new variable, insurance. So if there were any insurance payments over 0 to either Medicaid, Medicare, private insurances, if they were over 0, the payments, then I classified them as being insured. If they were 0 or missing, I classified them as 0, having no insurance. I also created a new variable called total tests. I counted the number of total tests of diagnostic tests and procedures received, which included MRI, CTs, surgeries, x-rays, lab tests, EKGs, etc. I also merged the original data set with another MAPS full year consolidated data set using the patient unique ID to add also sex and 5 different poverty categories. So this is my first research question. It looks at identifying the factors that determine whether an ER visit leads to an inpatient hospital admission. So patients sometimes can go into the ER, but then they can be treated and released on the same day, versus when they're admitted inpatient, they require longer stays for observation or additional care. Some of my independent variables were diagnostic tests and procedures such as MRI, surgery, x-rays, lab tests, etc., and insurance status as well. It's important to understand this research question, or look into this research question, because it allows the hospital administrators and healthcare professionals to look at which patients require extended care and to help improve planning and resource management. This is one of my data visualizations, which counts the number of ER visits by inpatient status. You can see there's kind of an imbalance of data. Specifically, there are 21% of patients who are admitted versus 79% of patients who are not admitted inpatient. Next, I ran a logistic regression model. We saw that certain procedures like MRI, CT scans, surgery, lab work, EKGs were linked to higher odds of being admitted. On the other hand, 2 of the strongest predictors, patients who had insurance and patients who were given prescriptions, were less likely to be admitted, and these were actually the strongest predictors of lower inpatient admission. So below you can see the logistic regression results for the coefficients. Insurance and prescription given had negative coefficients, meaning that they had lower odds of being admitted, whereas lab tests, related conditions, EKG, surgeries, etc. had more positive results. The results that, the predictors that were insignificant were X-ray, vaccinations, and mammograms. We see how the logistic regression performed. It had a true positive rate of 62.3%, which means that it correctly predicts those who will be admitted. But overall, the logistic regression model had an 82% accuracy rate. Next, I performed a random forest tree classification. This showed that also similarly to the logistic regression, that insurance was one of the strongest predictors, and prescription given. Prescription given was actually the second strongest predictor in the logistic regression model, whereas here it seems like lab test is the second one and then prescription given. We look at the performance of the random forest tree, and it looks like it has a similar true positive rate at 63.5% and an accuracy rate of an 81.7%. So the logistic regression and the random forest model had very similar results, around like 82% accuracy. One thing that the logistic regression did have an advantage compared to the random forest model was that it was able to kind of give more interpretability within the data set, because we were able to kind of see the negative coefficients, and so we were able to understand the direction of these effects and how these factors relate to the likelihood of an ER visit resulting to an inpatient admission. So in the random forest model, we were able to see that having insurance was a strong predictor, but we were not able to see which way that it was able to predict whether it was more likely or less likely for a patient to be admitted inpatient. But overall, for the best model, I chose the random forest model because it's able to handle imbalanced data better, because of the way that the model is designed and building hundreds of decision trees, each using a different subset of data. So I did choose using a random forest model was the best model and able to answer this research question. My second research question looked at what types of ER visits are most costliest for total ER expenditures. This question is important because it helps healthcare professionals allocate resources towards areas where there are high patient costs and hopefully make efforts in lowering costs without compromising quality of care. So the dependent variable I looked at was total cost, which was a continuous variable. Some independent variables were the diagnostic tests and procedures, similar to research question number 1. So you can see here, this is a box plot which shows the total cost distribution of ER visits. The median cost for the ER visits are usually around $578, whereas the maximum could be upwards to $195,314. There are quite actually a few outliers, and there's quite a huge range. As you can see here, these are all the outliers too for total cost. $195,000 was the highest maximum cost. Next, we can see kind of a left skewed distribution of total distribution of ER costs. You can see the majority of total cost, the majority of visits were less than $2,000 for total cost. The first model I ran was a random forest regression. You can see here the results showed that admitted was also the strongest predictor for total cost. But here in the multiple linear regression, we can see that patients actually admitted inpatient show a decrease of $1,589 in ER costs. I thought this was really interesting. This might also be because inpatient costs and ER costs might be billed in separate categories. Here you can see that MRI-CT had an increase, getting an MRI-CT had an increase of $936. All of these tests and procedures had an increase. EKG was interesting because it was had a p-value of 0.06, so it was kind of on the cusp of 0.05, but just wanted to know EKG also had an increase of $384, but didn't quite make the p-value of 0.05. So I thought that the best model was a random forest model. Performance-wise, it performed better on the RMSE, the MAE, and the R squared. This is also because the random forest model can handle outliers much better than the multiple linear model. It had much lower R squareds, MAEs, and RMSEs. These are important because the RMSE means that the predictions were much closer to the actual cost, and that the R squared captured 97% of the variation in ER cost compared to 13% in the multiple linear model. So performance metrics wise, random forest beat multiple linear model way out of the park, mainly because of how it handles outliers. So my third research question looks at what impacts the number of tests and procedures a patient gets done in the ER. My dependent variable looked at the total count of diagnostic tests and procedures, and my independent variables looked at insurance status, poverty category, which had 5 different categories here, and sex. One thing to note is that I did combine my original data set with a new data set, linking it with a patient ID. So I added sex and poverty information. So this is a bar chart of the number of ER tests by insurance status. You can kind of see a normal distribution here. Whether the patient did have insurance or didn't have insurance, it does follow a normal distribution. The number of tests kind of max out at 8 here as well. Next, you see a table. This is a proportion of patients by poverty category and insurance status. One interesting thing here to note is that those with patients who were near poor or low income actually had higher rates of insurance than compared to no insurance over here. That was pretty interesting. Next, I performed a multiple linear regression. So you can see here that high income was the strongest predictor, and next was insurance. So high income was associated with an increase of 0.24 tests, and having insurance was associated with having 0.17 fewer tests on average. You can see the negative coefficient over here. Next, I performed a Poisson regression. The results were very similar to the multiple linear regression, but the p-values for high income and insurance status was slightly weaker. So high income with an increase of 0.09 and insured patients receiving 0.07. Coefficients are slightly smaller here. And next, the third model that I did was a random forest regression. This also showed that poverty category was one of the strongest predictor in finding the number of total tests. So the performance of all the 3 models were very similar. The RMSE was 1.37, which means that the predicted number of tests was off by 1.37 on average, which is pretty high considering the maximum number of tests were 8. The mean absolute error was 1.12, and the R square was also really low, which was 0.008 or 0.011. Which shows that all 3 models kind of explain very little of the variation in total tests. The data actually had low variance of about 1.9, which means that most of the observations were very close to the mean. I decided to choose the Poisson regression because the Poisson regression can handle low variance and skew data very well. So I chose the Poisson regression. Next, I have my future scope and conclusion over here. So in conclusion, the emergency visit MAPS data provided really important insight into inpatient admissions, total costs, and number of tests performed. I performed different models such as the multiple linear regression, Poisson regression, random forest regression, random forest classification, and the logistic regression. Some future work to look into would be to kind of merge different data sets, the MAPS data sets together, linking it with the unique patient ID. This could include demographic details like race, age, geographical location, and even types of insurance. This could give deeper insight into patient health disparities or even patterns across different patient groups. And here you can see my references, my code, and then my video presentation I will be linking in here. So thank you.